Today I will be exploring the concept of dynamic needle tip positioning. Dynamic needle tip positioning involves using ultrasound guidance to track the tip of the procedure needle in real time using the short axis out-of-plane technique. Indications for ultrasound-guided vascular access includes insertion of central venous access for peripheral arterial cannulation and peripheral venous cannulation. Ultrasound use is absolutely indicated during placement of internal jugular venous cannulas and subclavian venous cannulas unless a time-critical intervention mandates otherwise, such as cardiac arrest. For use in peripheral arterial cannulation of the radial and femoral artery, it is especially useful for difficult arterial lines or for arterial lines needing greater than 2 attempts. For peripheral venous access, when conventional access placement methods have failed, and in patients with known or suspected difficult venous cannulas, in extremely sick or critically ill patients, dehydrated patients, patients undergoing chemotherapy, IV drug users, and patients with recurrent hospitalizations, using the ultrasound guidance for vascular access may be of benefit. There are no specific contraindications to the use of ultrasound in vascular cannulation. However, in patients with fistulas, in patients who have lymph node dissections or radical mastectomies on the same side as the intended cannulation, or for patients with peripheral arterial disease or poor arterial circulations on the side of intended cannulations for arterial cannulations, or patients with cutaneous infections or break of the skin barrier at the site of insertions, these would all be considered as contraindications to vascular cannulation, whether it is done with ultrasound or not. Techniques used in ultrasound-guided vascular cannulation include the long axis in-plane technique as seen in the picture on the left. The needle here is seen as a bright hyperechoic line. The short axis out-of-plane needling technique, as seen in the picture on the right, shows the needle which appears as a hyperechoic dot. The other technique commonly used is the short axis out-of-plane technique with dynamic needle tip positioning. And this is a modification of the short axis out-of-plane technique. Advantages of using the dynamic needle tip positioning technique include decreased incidence of posterior wall puncture and increased risk of first pass success when compared to using traditional palpation methods and using the long axis in-plane needling. There also seems to be decreased time to cannulation and increased rates of overall success in difficult cannulations when compared to using both the traditional techniques and long axis in-plane techniques. This only applies to difficult cannulations. It must be noted that the routine use of this technique for regular, uncomplicated cannulations offers no additional benefits, and it in fact may take longer than traditional palpation methods for cannulation. The steps for dynamic needle tip positioning include preparation, image optimization, vessel selection, advancing the probe, advancing the needle, and ensuring optimal placement within the vessel. Preparation involves gaining patient consent prior to doing any procedure. The next step is to gather the necessary equipment and adjuncts to the procedure. For venous cannulation, this would include local anesthetic, prep pads, flush, appropriately sized cannula, and maybe infusion lines and fluids. For arterial cannulation, this includes local anesthetic, arterial kits, flush, the transducer setups, and sutures or tape. The setup of the ultrasound machine prior to commencing improves the chance of success and decreases delays in the procedure. Prior to starting the procedure, the image must be optimized. The first step of image optimization involves selecting the appropriate probe. The lineovascular probe has a frequency of 5 to 10 MHz and a penetration of up to 9 cm. As we know, frequency is inversely proportional to depth of penetration. This allows for high resolution at the cost of poor penetration when compared to the convex and cardiac probes. For the purpose of a vascular examination, this probe will be more than sufficient. The next step is selecting the vascular preset if this is an option in your ultrasound machine. This preset optimizes imaging for vascular examinations. After that, you want to ensure that your image is oriented. This can be done by lining up the marker on the transducer to correspond with the marker on the screen. That means what is left on the transducer is seen on the left side of the screen and vice versa. After that, centering the image is what should be done. If the guide is available on your ultrasound machine, this can assist with keeping the image centered during the entirety of the procedure. It is important to select the appropriate depth and focus of the image, and this would help to improve the image quality. For peripheral cannulations, a depth of 2 to 3 centimeters may be sufficient, as you want to see the vessel and just posterior to it to rule out posterior wall puncture during the procedure. Use your discretion when selecting the depth of the image based on the depth of your vessel. With regards to gain functions to change the overall strength of the returning echoes, and it functions as an amplifier, making the image brighter or darker. Adjust the gain so that the fluids look anechoic or dark, and the contrast appropriately with the solid or hyperechoic structures in your image. Selecting the appropriate vessel increases the chance of cannulation. Vessels with an anterior-posterior diameter of 2 to 4 millimeters increases the chance of success, and there's an even greater chance of success in vessels that are greater than 4 millimeters in diameter. The depth of the vessel from the surface also influences the chance of successful cannulation and longevity of the cannula. A short pathway to reach the vessel increases the proportion of the cannula within the lumen of the vessel, and this hence decreases the risk of kinking and dislodgement, as well as tissuing. Increased risk of success has been noted with vessels 0.3 to 1.5 cm from the surface. The length of the vein will determine the size and the length of the cannula that can be used. Ideally, the vessel should be relatively straight and long enough to accommodate the catheter comfortably. Vessels that are branched or contain valves, the site of the cannula should be away from the point of branching so that the catheter can be accommodated within the vessel without obstruction. It is of utmost importance that the vessel is patent prior to cannulation, and non-compressible vessels should not be cannulated. It is also wise to appropriately identify the type of vessel that is to be cannulated. Color wave Doppler can be used to demonstrate whether the vessel to be cannulated is arterial or venous. Non-pulsatile phasic flow will be seen in veins, and pulsatile flow patterns will be seen in arteries. Once preparation is complete and the imaging is optimized, the vessel is selected, then you can begin. The first step is deciding the initial point of ultrasound placement. After that, the needle is entered into the specimen and seen on ultrasound. The probe is then advanced, the needle advanced to meet it, and these two steps are repeated until the vein is cannulated. This will better be demonstrated in the following video. This video demonstrates two images. At the top, we have the longitudinal image of the tissue for better understanding of the procedure. At the bottom, we have a short axis out of plane view that will be seen on the ultrasound screen as the procedure is being done. This initial point at which the ultrasound is placed is prior to insertion of the needle. Seen below, the vessel is noted in the center of the ultrasound image. The needle is then introduced into the tissue at a 30 to 45 degree angle in the direction of the probe. Let's take a look. Great. Some ultrasound probes have a central marker that allows you to estimate where the middle of the image is. The needle should be advanced until the tip of the needle is seen on the ultrasound screen, like this. It must be noted that the tip of the needle seen on short axis out of plane imaging is no different from the shaft of the needle. It's very difficult to tell the difference. Then how would you know if this is actually the tip? Beyond the tip of the needle there is nothing, hence you will lose the image. The point at which the image is lost can be assumed to be the tip of the needle. The ultrasound probe is then advanced in minuscule increments to lose the image of the needle tip. The tip of the needle again is advanced until it is seen on the ultrasound screen, and these two steps are repeated until the vessel is cannulated. This video shows a real-time example of the technique being used. As seen, in the center of the screen we have the vessel, and the guide is turned on as seen by these yellow dots in the middle of the screen, and that functions to keep the vessel central during the procedure. The depth has been adjusted to 3 centimeters, and this allows the image above and a little posterior to the vessel to be noted. This allows the posterior wall to be in full view during the entirety of the procedure to rule out a posterior wall puncture. The brightness has also been adjusted so that there is adequate contrast between the anechoic vessel and the hyperechoic surrounding tissue. As the video starts, you can see the appearance of a hyperechoic dot. This dot represents the needle tip. As the ultrasound probe moves forward, the image of the needle tip is lost, and then the needle is advanced to meet the ultrasound probe and it appears again. This procedure is repeated. As the needle tip approaches the anterior wall of the vessel, the anterior surface is seen to be distorted. As the needle advances further, it pops through the anterior wall and enters the vessel. Once within the vessel, the cannula should be advanced further using ultrasound guidance to increase the chance of successful cannulation and length within the vessel, as being seen on the screen. While conducting this procedure, the needle tip visualization can sometimes be problematic. Some factors that can improve needle tip visualization in ultrasound guided procedures include using a larger caliber needle, adjusting the tip of the needle so that the bevel face upwards, or using hyperechoic needles, none of which is helpful for dynamic needle tip positioning for purpose of vascular cannulations. Things that can actually be done are ensuring that the needle and the ultrasound is properly aligned, optimizing the tilt and the angle of the probe to ensure a perpendicular angle, and the angle of insertion of the needle should be 30 to 45 degrees. In this image borrowed from the Nysora website, we have 5 maneuvers that can be used to improve needle visualization. That includes alignment, tilting of the probe, applying downward pressure, rotating the probe, and the healing maneuver. For dynamic needle tip positioning, the use of the tilting maneuver and the healing maneuver are especially important. When using the tilting maneuver, the aim is to achieve optimal beam reflectiveness, which would enhance needle tip visualization. When the needle is not visible, this is called anisotropy. Anisotropy occurs when it is impossible to visualize the desired structure of interest due to the loss of the sound waves resulting from decreased reflection back to the transducer. To get an optimal image, the needle and the ultrasound probe should be aligned at a 90-degree angle. This perpendicular angle maximizes the reflection of reflected ultrasound beams from the needle. The other maneuver, the healing maneuver, is very useful. This involves applying pressure or tilting to the opposite side of the probe to position the ultrasound probe and the needle as close to a 90-degree angle as possible. Lastly, once you have placed the cannula within the vessel, you want to ensure that the placement is optimal. Ideally, the cannula should be placed centrally, and the length of the cannula within the vessel should be greater than 2.75 centimeters, and this would increase the longevity of the cannula and increase the success. And with that, this video has come to an end. Hopefully, with these tips and tricks provided, you should be able to use the dynamic needle tip positioning technique to cannulate a vessel using ultrasound guidance. I hope that you've enjoyed this presentation, and thank you for watching. That is all for today.